Exactly. Good morning, everyone. This is the first time that we see each other. My name is Victor Pulgar. I teach pharmacology here, so you will see me coming into different classes. We have a couple more topics in this course that we will review later, and then in some other classes into P2 and P3 years. Well, I always talk about drugs, action, mechanisms, and that kind of things are the most important for me for the questions that I can have for the exams, and some characteristics of drugs. So I'm originally from Chile. Okay, so you can feel my accent maybe a little bit. I have an undergrad study abroad course actually that I took the first time a student from Campbell to Chile last December. So that's exciting. Okay, so today is we're going to talk about two important mediators of hypersensitivity reactions. That's the topic that you are talking this day, discussing in this class. So we'll first talk about the epinephrine, like a little bit of introduction to adrenergic pharmacology, okay? What that means and why epinephrine is important to talk about in this course and in this section. And then we'll talk about some other one in the second part of the session. So we talk about the mechanism of action. Well, we talk about what epinephrine is first, and then the mechanism of action, and then why this is important for this particular topic of hypersensitivity reactions. Okay, so what are the pharmacological basis of the uses of this to treat some conditions that we will be discussing, and then how they are used, and then some side effects and important interactions of this drug with somebody. Okay, when we talk about drugs, we need to talk about how the drugs work, the targets of the drug, right? But also what interaction that drug may have with some other drugs. I mean, there's a full area it's called drug-drug interactions. That it's not only drug with drug, but it can be drug with food, with drug with some supplement, drug with some other things. Okay? So drug-drug interaction is a very important area too that you will see repeatedly in the different topics that you discuss, not only in this course. Well, epinephrine. It's a drug, right? It came in different formulations, different presentations, and it's used to treat different conditions. So we will see why. Okay? So in order to do that, we'll discuss what epinephrine is and the target, okay? What family belongs, etc. All the stuff. So you see that there's some ways to be administered, like injectable thing. There's aerosol formulations, and I can tell you there's no good oral administration because it's very sensitive to the stomach environment, etc. And then you want to hear about the EpiPen, very rapid action when it's needed for those allergic anaphylactic reactions. So what is epinephrine? Well, that's the structure, okay? And I can tell you something about this. This portion here, this is a particular chemical group called catechol. Catechol. Okay? So anything that any chemical that has that group is called a catechol. Okay? And then this particular one that we have here has another group here that is an amine. So that's why the name of this, or the chemical class that this epinephrine belongs to, is catecholamines. Okay? Catecholamines. And there are several catecholamines. What I mean with that is that have the catechol and an amine group. And most of them are neurotransmitters. You probably heard about norepinephrine, dopamine. It's a catecholamine too. Okay? And some of them are hormones. They have some dual function. But that's the basis for the name of catecholamines. Okay? It's endogenous produced too. Okay, so it has a function in our body. Okay? as many drugs that you can think about. But this one, endogenous is produced, right? Is usually produced where the catecholamines are produced. That is in the adrenal gland. Right? You know where the adrenal gland is? Top of the kidney. That's why it's also called suprarenal. It's the same name for the same gland. Okay? Adrenal or suprarenal. Okay? And the adrenal is kind of a synthetic powerhouse. No? It produces a lot of hormones, neurotransmitters, etc. All the stress hormones are produced in the adrenal gland, cortisol, all the kind of things, corticoid, different type of corticoids, and catecholamines. Okay? Epinephrine is produced in the adrenal gland, and when it's produced in the adrenal gland, acts as a hormone, okay, because it goes into the blood and goes into the everywhere where receptors may have. But also it's a neurotransmitter. It's also produced in the terminal nerves, right, upon stimulation, and we'll see a little bit of that process in a moment. Okay, so it's a hormone, right, and it's a neurotransmitter. The fight or flight response, you probably heard about this. Okay, it refers to a set of physiological responses mediated by a particular portion of the nervous system. It's called the autonomic nervous system. And more specifically, the sympathetic portion of the autonomic nervous system. Right? And you know that there are many functions that we don't control in the body. We don't control breathing normally, right? We don't think about that. Digestion, anything, heartbeat. We don't think about that. It's not voluntary. Okay, so those actions are some examples of what's called the autonomic function. The autonomic nervous system that has two arms. The autonomic nervous system has here is the autonomic nervous system that controls it's called the involuntary responses, right? And we have the sympathetic and a parasympathetic division. Now, I'm not going to talk much about this, just you probably heard about this before. And the fight or flight response is a set of physiological responses, as I say, commanded by activation of the sympathetic arm of the autonomic nervous system. Why I'm saying this? Because that's where this neurotransmitter epinephrine plays a very important role. Okay? A very important role. It's a whole area called energy pharmacology that talk about the synthesis, the secretion, the target, etc. of these catecholamines. Okay? And all of those talk about these sympathetic terminal nerves. We'll see a little bit about how this neurotransmitter is synthesized, etc. But just to give you an extra idea about the endogenous functions of epinephrine, right? Well, it's intimately linked to this activity of the sympathetic autonomic nervous system. Right? It's the catecholamines are the neurotransmitters of the sympathetic autonomic nervous system, and this system innervates all the organs that you can think about. Okay? And it's similar to the other part too. The two arms of the autonomic nervous system innervate all the organs that you can think about, and they fulfill, we can say, complementary functions. But we're talking about the sympathetic, and we have the sympathetic that there are terminal nerves that secrete epinephrine and norepinephrine mostly, but both. And the adrenal medulla that release epinephrine, that's the one that we talk about, that acts as a hormone. And you have here innervation. This is a very basic diagram that shows how this the sympathetic neurons, we can say, come together in what's called a sympathetic chain ganglia. And from there, you have nerves that go to two different organs. Okay? That's just to show you how things work very briefly on the sympathetic autonomic nervous system. For the parasympathetic, it's kind of similar. There are some similarities and differences, but I'm going to go into that detail. We are mostly talking about the function of these catecholamines, as hormones and as neurotransmitters. And as neurotransmitter, they fulfill the functions of the sympathetic part of the autonomic nervous system. You can interrupt me anytime if you have a question or something, okay? Or if you don't understand what I say. That happens sometimes. Or if I start speaking in Spanish, that's something happens too if I'm so excited about it. Okay, synthesis, catecholamines. Catecholamines, as I mentioned, they are synthesized in the adrenal gland, right, where when they are secreted, act as hormones, or in the terminal nerves, and when they are produced there and they are released there in the terminal nerve or the sympathetic arm of the autonomic nervous system, they will work as a neurotransmitter. Okay? You all heard about neuronal transmission. You all know about the synaptic transmission, what it is. I'm going to just briefly discuss some important things. First, synthesis. Okay, as a neurotransmitter, and also in the adrenal gland, but let's say as a neurotransmitter, all these catecholamines are synthesized in the terminal nerves. Okay, they are not synthesized somewhere and carried to the terminal nerve. They are synthesized there. That means that all the synthetic machines are there. Starting from the substrate for these catecholamines to start the synthetic pathway is an amino acid. The amino acid tyrosine. This one. Okay, that's the starting point of the synthesis of catecholamines. Okay, and then we have a series of reactions with different enzymes catalyzing those steps. Okay, and then they produce some other compound, and that compound becomes the substrate for another enzyme, and then they become the substrate for another enzyme, etc. It's a cascade of events, of enzymatic events, right? So we start with tyrosine, and then at some point, after a couple of steps, that one and that one, we have this one. This is a catecholamine. It's called dopamine. Okay, you can see some of the steps there. That there's decarboxylation, some hydroxylase activity, etc. Produce dopamine. Okay, and then the synthetic pathway continues, and dopamine becomes the substrate for another enzyme, this one here, and then we have norepinephrine here, and then with another enzymatic state, we have epinephrine. Okay? And this synthetic pathway exists in mostly every sympathetic neuron, okay? Except some, in particular region of the central nervous system that don't have this part on the right. And because they don't have those enzymes, they only produce dopamine. And you probably heard about the dopaminergic system. Neurons that produce dopamine as neurotransmitters are very important for some conditions. There are some diseases that are affected by these neurons that produce dopamine get damaged or destroyed or something, or dysfunctional. Well, those particular neurons, they don't have all the synthetic pathway, only produce dopamine. Okay? But in the sympathetic system, most of them produce the whole thing. So you have norepinephrine and epinephrine. Sometimes more norepinephrine what is released in the terminal nerves, and epinephrine is more released in the adrenal. That's the synthetic pathway is the same. Tyrosine is the beginning, okay? The amino acid tyrosine. Another thing I'm going to say, you know that there are techniques that we can use to see neurons, okay? And those techniques usually use staining, something that can stain a tissue, and then we see some lines there, and we can say with we can be sure that those are neurons if we stain it with something. And then for the catecholamine pathway, I'm just going to say this tyrosine hydroxylase is the marker. Okay, if you find a tissue that have many different neurons, because that happens, okay, tissue that receive innervation from different types, and you think, well, is there any sympathetic neuron here? Well, what people do, they use as a marker the first step of the synthetic pathway. that they look for the enzyme tyrosine hydroxylase, and if we find that, we say, oh, this is actually a sympathetic neuron. Okay? I don't have a picture, but I worked sometime in doing that years ago, and you can actually see how those neurons, the location of those neurons. Again, tyrosine hydroxylase is a marker of sympathetic neurons. Okay, this is a very basic diagram of sympathetic nerve terminal. Okay, and you see, just imagine that this the axon came here, right, and this is the end. Okay, and then here it will be the postsynaptic cell or the tissue, maybe, if it's a terminal that arrived to the tissue. And the idea here just to show you where the synthetic pathway of catecholamines is located and what happened with this neurotransmitter once they are released. What happened with this norepinephrine or some others when they are released. So, as I mentioned, the synthesis happened in the terminal nerve. Right? You can see here the enzyme in charge of the first step of the synthesis, tyrosine hydroxylase. The substrate, the first substrate here in the pathway, the amino acid tyrosine, right? And then we have the different steps. Here you see the production of dopamine, and then dopamine gets incorporated in this things here, that's called vesicles. Okay? And inside those vesicles, the latest states of synthesis happen, and then you have this norepinephrine. You have some epinephrine too, but norepinephrine there. And some of the things I want to mention here, this neurotransmitter, they're never released alone. They're also always released in conjunction with something else. So you will have norepinephrine, in this case, ATP. That P there means absent P, that's another type of neurotransmitter. Okay, so there's always this vesicles stores several neurotransmitters. That's why you have ATP and proteins. But once they are there, they are there. So the terminals are usually full of these vesicles. Okay? And when a stimulus came to this terminal, usually in the form of an action potential, right? So let's draw here something, I don't know. I don't know how to draw an action potential. These are action potentials that come here. Depolarization of the membrane, etc., traveling in one direction. And then arrive here, there is a calcium channel. That's very important because it's voltage dependent. And then open, and then calcium increase here inside the terminal. That's calcium going up. The concentration of calcium here. And this is a very important event because that event promotes the fusion of the vesicle with the plasma membrane of this terminal and the release of the neurotransmitter. Okay? And that's very simple steps of neurotransmitter synthesis and release in the terminal nerve. Now, what happened after that? Well, the neurotransmitter is there, is released from the terminal, right? And in this case, norepinephrine, and here you see is here in the what's called the synaptic space. Okay, the synaptic space. And here you can have different effects. It depends. It depends where this terminal arrives. Okay, it depends if it's another neuron or if it's a tissue, etc. But the possibilities are some, not many. But first, this neurotransmitter can go and interact with receptors. Okay? You don't know about the receptor, what receptor is. We tend to use the term receptor, and we don't think too much about the complexity of this. Right? The receptor usually, not always, sit in the plasma membrane, right, and bind something. And that binding can be a small thing, can be another protein. Well, receptors are protein first. And then, but usually it's a small chemical that binds those, and those called agonists, and those activate the receptor. I'm not going to go into all that. There's a class about that, about binding. Okay, so you have the receptors, right? And in this case, because we're talking about adrenergics, and they are called adrenergic because they are synthesizing the adrenal gland. Okay, that's what you will say about adrenergic. That name refers to things that are synthesized in the, actually, not anything, catecholamines that are synthesized in the adrenal. Because cortisol, corticosteroids, hormones also, sex hormones are secreted in the adrenal gland, but they're not adrenergic. Okay? But this refers to catecholamines synthesized in the adrenal, adrenergic agonists. And then the receptors that bind to them are called adrenergic receptors, or sometimes adrenal receptors. Say that. Okay? So there is this norepinephrine, epinephrine, etc. that is released there, can bind the receptors and produce an action in the postsynaptic cell. Right? And then the synaptic transmission continues. That's one possibility. The other possibility is that they can actually they can be subject to reuptake, take it back into the terminal. Okay, and that there's a bunch of transporters that do that. Okay, you've already heard about those. In this case, we call the norepinephrine transporter, for example, the one here. Okay, and that one, a small portion of this neurotransmitter that's released will go back, and that's called reuptake. Okay, reuptake. Or the other possibility is this neurotransmitter release here will act on receptors in the presynaptic membrane. Okay, and usually those are adrenal receptors. There is a particular family of adrenal receptors that fulfill that function, and those are called autoreceptors in general because they are able to regulate the synthesis of this, the production of catecholamines. So like a negative feedback. Okay? So the neurotransmitter can act on the receptors on the postsynaptic membrane, and they can be subject to reuptake, coming back, and then recycle in the process, put inside the vesicles, and then come back. There will be release of stimulation, or they can act on those autoreceptors that are usually inhibitory, like a negative feedback. Okay? So those are the, and also some of the things that can happen is they can degrade it. So that's the other thing, catabolism. Okay? Catabolism that means that they can be degraded. I mean that there are some enzymes that can usually destroy the catechol group. Okay? Through different reactions. They can oxidate it, they can methylate it, etc. If you have a methyl group add to the catechol group, that's not a catechol group anymore. It will not act as a catecholamine. The most important enzymes, we already heard about those. The monoamine oxidase. Okay? That's a target of an important family of drugs. Or the other one is the catechol or methyl transferase. Okay? CONT. So those are two enzymes involved in the degradation of catecholamines. Okay? Okay, so there are several possibilities for this catecholamine that is released in the synaptic space. So, well, a little bit about the receptors. Because the receptors are key here. Okay? Because you have this neurotransmitter that is released, or you have this hormone that is synthesized and going to the bloodstream. Well, in order to function, you need to bind something. Okay? You need to bind something. A very famous chemist saying more than 100 years ago, nobody active is not bound. Nothing active is not bound. Okay, and that's what the beginning of the concept of receptor that today we use commonly. Okay? So, talking about where these catecholamines bind. Well, they bind to receptors, and because they are adrenergic agonists, you have some adrenergic receptors. It's logical. Yeah? And you have families of those receptors. Okay? There's a history behind the names, etc. But I'm not going to go into that. But you have a group that's called alpha, and the other group that's called beta. Okay? And then you have subtypes in those families. You have alpha 1 and alpha 2. And then you have beta 1, beta 2, and beta 3. Okay? Alpha and betas. What is important to remember is those receptors, first, they have different locations. They are not everywhere. Okay? And that explains the function of these agonists. Because some of the receptors are predominant in some tissues, where these agonists will produce the most action. Okay? The other thing is, what happens once these receptors get activated? You all know about the second messenger and the G protein cycles, etc. I'm not going to go in much detail about that. But you know that there are different ways, different action that the receptor activation will produce inside the cells. All of these that I'm talking about are GPCR. You know what GPCR means, right? G protein coupled receptors. So that means the 7 transmembrane receptor that are coupled to the G protein. There's a trimer, right? And then you have an alpha subunit in those G protein. That's the one that actually will activate the effect of the particular system. And all the receptors are coupled to different second messenger pathways. But there's a couple that are more important, okay? And so I'm going to mention briefly. So, in case of the alpha-1 receptor, for example, the alpha-1 activate a G protein type subtype Q, and then you have a phospholipase C as the effector, and you know that that will produce some lipid mediator like IP3 and diacylglycerol. And what happened with that? Well, it's able to increase calcium intracellularly, and then that will trigger a bunch of other effects, activating kinases, etc. And then that will be the cellular, or the trigger of the cellular effect produced by the activation of the alpha 1. Alpha 2 receptor acts through a different system, acts through the cyclic AMP second messenger system. So you heard that was the first second messenger system described. It's highly investigated, still today. Okay? It's involved in many different pathways and different organs, etc. And activation of an alpha 2 receptor, this type of adrenergic receptors, affect this pathway because it will inhibit the effector, the aluminum cyclase, decreasing the second messenger cyclic AMP, and in that way will regulate a bunch of other things. Okay, so in terms of the alpha receptor, we have activation of the phospholipase C as an effector in the case of the alpha 1, and in the case of the alpha 2, an inhibition of adenine cyclase as an effector. Okay? Beta receptors, on the other side, they all affect the same pathway, okay? And all of those have the same effect, intracellular effect. All of those increase cyclic AMP. Okay? Cyclic AMP goes up. It doesn't matter if you are activating a beta 1, a beta 2, or a beta 3. Good. Then, in different teacher already mentioned that, so that will modulate the action of this agonist. Okay? And what else we can say? You probably will see at some point, maybe, that the alpha family have subtypes. So say the alpha 1 has different subtypes, and the alpha 2 also has different subtypes. Okay? I'm not going to go into much detail about that. Just to tell you that some of the action of this agonists also depend on which subtype of receptor, say 1A, 1D, etc., 1C. Okay? But today we don't have pharmacological tools to interfere with subtypes of receptors, but we have pharmacological tools to activate and block alpha 1, alpha 2, beta, and beta receptors. Okay? Some beta 1, some beta 2s more specific. Okay? Okay. So those are kind of very briefly about these adrenergic receptors. Important things important to remember, again, alpha 1 and 2, the transduction pathway associated to those, and the transduction pathway associated to the beta receptors. Okay? Good. Okay, well, this was what I was talking about. I should have put this before. In case of the alpha 1 receptor, here you can visualize how the thing works. You have the agonist, let's say epinephrine or norepinephrine or some other catecholamine that I started to add here. You have this 7 transmembrane receptor, 1, 2, 3, 4, 5, 6, 7. 7 pass through the membrane. That's what's called 7 domain transmembrane receptor. And then you have here a depiction of the G protein. Okay? And this alpha will be the subunit that will detach from the rest upon activation of the receptor, and then that will interact with the effector. In this case, it's phospholipase by C. And when that happens, then you will have activity of that enzyme that produces what's called the secondary messengers. And in this particular case, for this particular transduction pathway, we have the production of IP3 as inositol 3-phosphate and diacylglycerol, DAG. Those are the 2 second messengers that are produced in this pathway. Okay? And what will be the cellular effect? Well, there are many effects of activation of alpha 1 receptor, and all of those are mediated by an increase in calcium, intracellular calcium, and the activation of some protein kinases. Okay? You know, protein kinases is a very important enzyme. That what they do, they transfer a phosphate group from usually from ATP to a protein in a process called phosphorylation. And that is a small group compared to the big structure of a protein, but you can change the function, you can change the structure, you can change the location, you can change a lot of things. Just the addition of one phosphate group. And that's the activity that these kinases are responsible for, and then they are able to modulate many different cellular processes. Okay? Good. Alpha 2 and beta, they work through other pathway, right? The difference is that alpha 2s are here, and betas are here. Just to didactic purposes, we can say. The effector is, in this case, is adenylyl cyclase. Okay, this is the AAC. Okay, and the activity of adenylyl cyclase produce a second messenger called cyclic AMP from ATP receptor. So what happens when these beta receptors get activated? They have a G protein, in this case a GS. S because this was one of the first things discovered. When people discovered this, they found that when they activate some type of receptor, cyclic AMP went up. And they say, well, this is stimulating something. That's what they call S, GS. And the alpha subunit of that G protein will detach and will activate the effector, producing cyclic AMP. And cyclic AMP will do some other things. But on the other side, if we activate alpha 2 receptors, they are they interact with a G protein too. It's called GI, right? Or inhibitory. And because the alpha subunit will inhibit the effector. That's the problem. So in one case, cyclic AMP will go up, and in the other side, case, cyclic AMP will go down. That's and the level of that second messenger will again modulate the activity of, in this case, a kinase, a very important kinase, this one here. It's also called protein kinase A. A because it was cyclic AMP, one of the messengers that was found to activate. And that kinase is everywhere, actually. And when activated, it does a lot of things. It phosphorylates things. That's what the kinase do. And usually there is some phosphorylation of kinases, etc., etc., some more complex. But in this case, it's just cyclic AMP. The second messenger goes up when a beta receptor is activated, goes down with an alpha-2 receptor. Okay, so what happened with this receptor get stimulated? And I mentioned that they are present, they are different expression, okay? So they are not present in every organ, but they are present in many organs, okay? And there's we'll talk some specific things that has to do more with the drugs that are used to control the receptors. For example, at the level of the vascular system, activation of alpha-1 receptors. Let's say alpha-1 receptors get activated, there's a epinephrine or epinephrine release. What will happen? Well, you're always going to have vasoconstriction. Okay? The vasculature, the diameter of the vascular will narrow. Okay? And then you will have increased peripheral resistance. Okay? So hyperactivation of those receptors actually increase blood pressure. That's one effect of activating alpha-1 receptor. Alpha-2 receptors, well, alpha-2 receptors, remember that I mentioned that they can be autoreceptors? No, I didn't mention that. Autoreceptors, alpha-2 receptors can be autoreceptors. That's what I'm saying. So that means that when the autoreceptor can have a negative feedback on the release of neurotransmitter, well, they can actually inhibit the release of neurotransmitter. Okay. Acetylcholine, I didn't talk about that, but acetylcholine is the neurotransmitter of the parasympathetic system, the cholinergic transmission. That's another similar to adrenergic, but with some differences too. But autoreceptors mediated by the alpha-2 can also decrease the release of acetylcholine. Okay. They kind of have a negative feedback loop on the release of neurotransmitters. Okay. Okay. And also there's some other effect at the level of the pancreas. Okay. So some other actions. Beta receptors. Beta receptors. You all probably have heard about the beta blockers, a big family of drugs. They're very important in cardiovascular diseases. Very important in controlling heart function, actually. Okay? So there are many conditions like heart failure, hypertension even, and some others where drugs that interfere with the system are very important. We'll talk about that very heavily in 611 next year. But in the heart, we have a lot of beta receptors. Beta receptors control all the cardiac function. Okay? And then we have what will happen? Well, we have mostly beta 1 in the heart. There's some beta 2s too. Okay? But beta 1s, and what happened? Well, when they are activated, when the beta receptors get activated, contractility will increase. Contractility will increase. Myocardial contractility. Heart contractility. Okay? It's called the positive inotropic effect. Inotropy means contraction of the cardiac muscle. Heart rate will go up too. The rate, the amount of beat per minute will go up too. Okay? You know, our heart rate goes between 60 and 100 normally. Well, it can go to 200 easily in certain conditions. So that we have a full range. And those increases in rate are mediated by activation of these receptors. Okay? Conduction, we're not going to talk much about that process, but we'll talk in detail later. But the conduction through the cardiac conduction system is called the drumotropy. That also will increase. Okay? And the increasing heart rate, increasing chronotropy. So we have inotropy, chronotropy, and homotropy, and all of that can increase due to beta receptors activity. At the level of the kidney, there is an increase in the release of this very important hormone, We will talk about that in another blend. And in the adipocyte, those cells that store energy in the form of fat, lipolysis, okay? The degradation of those and the release of free fatty acid increased. So those are activity of the beta receptors. There are beta receptors in the vasculature too. Okay, they're a little bit more of beta 2s than beta 1 in the vasculature, and a little bit more of beta 1 than beta 2 in the heart. That's it. But in the cardiovascular system, these beta receptors are very important. So what happened with the beta 2 receptors? Well, you probably heard about some drugs that are used to relieve contraction or congestion of the airways. Those inhalers, the people that have asthma, for example, or some other respiratory conditions use. Well, and why is that? Well, some of those can be beta adrenergic agonists. I mean, that activate beta receptors because there's a lot of beta receptors in the smooth muscle in the airways. Okay, and they produce dilation. Okay, so that they can relax the airways. Okay, bronchodilation. Okay, activation of beta receptors can dilate the airways. Okay, that's why that's the basis for this very important family of drugs that are used. They can also dilate the vasculature, not as much, but they produce a little bit of dilation. They can relax the muscle too, and some other metabolic action. Okay, in terms of increased glycogenolysis and release of glucagon. So that's the main action of beta receptors. Okay, they're very important in the airways. Okay, so what epinephrine is used for? Well, you have a different presentation already mentioned, okay, and I already mentioned that it can be given by injection or inhalation, right? Oral administration is not good because they are very labile. They can degrade rapidly by these metabolic enzymes, okay, and that kind of things. It crosses the placenta and does not cross the blood-brain barrier. That's important. You know what the blood-brain barrier is? Have you heard about that? The BBB. Where is the BBB? You think? It protects the brain. That is called blood-brain barrier. Okay? And it was discovered because somebody many years ago was doing something else, and they inject some dyes in animals, experimental animals, and the animals then died. But when they wanted to look at the organs, all the organs were stained with the dyes, except the brain. So there was something that protected the brain. And actually, it's a barrier that is in the vasculature that irrigate the brain. And all the different tiny vessels that irrigate the brain, they have a different type of barrier with tissue and other vessels. And that's the blood-brain. It's a very important target today to study how to deliver drugs to the brain, which is important for many different diseases. Okay, so we're talking about epinephrine. Where epinephrine is used? Well, you can think that epinephrine will go and activate those alpha receptors and the beta receptors. Well, if there is, let's say, bradycardia, lower heart rate, for example, or hypotension, that means lower blood pressure. In that condition, if we use epinephrine will go and activate those alpha and beta receptors. Okay, will constrict the vasculature, increase the pressure, right? So we'll come back the pressure to the normal level, increase the heart rate too. That also will increase pressure. That will be important. Okay, if activate the beta receptors, it can help maybe in a condition where you have a congestion or closing of the airways. Okay, well, there are some conditions that do just that. For example, anaphylaxis. Okay, And anaphylaxis, this response to some intense allergens, etc., and other things. Then you can have bronchospasms. You can have hypotension. Okay? You can have angioedema, with extravasation of fluid from the vasculature, etc. So having a constrictor, having something that increases pressure, something that opens the airways is good. So that's the basis for the action of epinephrine in treating anaphylaxis. Okay? Also, because it activates all those receptors in the heart, in the cardiopulmonary resuscitation, epinephrine can be also used in very serious cases. Of course, in everything that have bronchospasms involved, okay, like an asthma. Status asthmaticus is an asthma, but much more serious, actually. It can be fatal. Okay? So, in those conditions, that's why you have the EpiPen, etc. Okay? And acute hypertension, in case of hypertensive emergencies, that epinephrine can be used too. And in combination with local anesthetic agent, because you have a local surgery or something that's happening there, and you apply an anesthetic. Well, you want the vasculature to be constricted, actually, to avoid the diffusion of the anesthetic so quickly. So that's another use of this epinephrine, okay, to reduce bleeding or inducing local vasoconstriction, etc. Okay. Yeah, I'm not going to talk much about it because I need to explain what mydriasis and meiosis is. This is something that has to do with the opening of the pupil, but that's under control of the sympathetic system. I'm not going to talk much for now. There's different dosage for this. Okay, I'm not going to require from my question for you to remember these numbers. Okay, just remember the different dosage depending on the condition. For anaphylactic shock, for example, there's some injections for hypertension, etc. Different things. I'm not going to put more much emphasis on it. Some side effects. Well, they can, they can have some different. If there's too much of opening of the airway, can produce some respiratory difficulty, for example. Vasodilation of some type of vessel can produce headaches, etc. Some other muscle effects too, because these receptors are everywhere. If there's too much, you can have arrhythmias and hypertension if you have too much stimulation of those cardiac receptors, right? And that kind of things. If patients are taking some other drugs that can interfere with adrenergic transmission, like some other beta blockers, cocaine is actually a blocker of the reuptake process. So imagine if you have cocaine, a person with cocaine will have a lot of norepinephrine and epinephrine in the synaptic transmission, produce a lot of effects. Okay? A lot of cardiac effect, muscle effect, etc. Amphetamine, the same thing. Amphetamines increase actually the production of neurotransmitter. In people using anesthetics, also there's some side effects that need to be, because can be some potentiation of some effect. In pregnancy, there's category C, meaning that there is some evidence in animal models that can be toxic in pregnancy, but there's no evidence in human yet. So it's used with caution, usually not used. And there's some cellular interaction that epinephrine may have. Okay? There's a potentiation with thyroid hormones of the action of epinephrine. Some antihypertensive agents will have like what's called a physiological interference because epinephrine is able to increase pressure. Antihypertensive agent will lower pressure, so that's kind of drug-drug interaction too. The different levels of drug-drug interactions. Already mentioned that can be a potentiation of the anesthetic effect, or because we have a decrease of the blood flow, especially in topical applications. And some other drugs that interfere with the adrenergic pathway. Those tricyclic antidepressants usually interfere with serotonin mostly, but also with adrenergic. Okay? They are, we would say, the ones that are blockers of reuptake. They can affect the reuptake of adrenergic too. And of course, there's a family of drugs that are inhibitor of these catabolic enzymes, the MAO inhibitors, and also can increase the endogenous levels of epinephrine. And we'll talk about histamines in a moment. Okay, 9:50. Thank you. Let's rest for 10 minutes.